discuss about the uh, medical mycology. We have discussed about general or basic mycology, superficial mycology or mycosis. Now we are in the subcutaneous mycosis step. Compared to superficial mycosis, subcutaneous mycosis, which cause devastating illnesses, not only cosmetic, which causes mycetoma and other infection, they require treatment as soon as possible. They cause chronic granulomatous infection of the subcutaneous tissues, usually on the extremities, hands, feet, can extend to the lymphatic sperm or sinus tracts, caused by a variety of fungi and bacteria-like fungi that live in the soil, saprophytes. Subcutaneous mycosis we are classifying as mycetoma, eohypomycosis, chromoblastomycosis, spirotrichosis, lobomycosis, rhinosporidiosis. But in this level, mycetoma, chromoblastomycosis, and spirotrichosis, that will be enough. About mycetoma, Madura mycosis, so Madura foot. It's a chronic, slowly progressive granulomatous infection of skin and subcutaneous tissues with the involvement of underlying fascia and even to the bones, which can cause chronic osteomyelitis, commonly affecting the extremities. It was earlier or firstly reported in South India, Gil by Madurai. That's why it's termed Madura mycosis or Madura foot. It's in tropical or subtropical countries of Asia, Africa, Central and South America. It's common. Madura mycosis. Fungi associated with fungal mycetoma are opportunistic. They are more common in men because they are the one who works in paddy fields, tropics, chains, jungles. So, by the prick injury or subcutaneous inoculation from the trauma or puncture, they cause this infection. That's why these are more common in the extremities. Post-traumatic chronic infection of subcutaneous tissue. Further, causative organism, eumycetoma, that is true fungi, or actinomycetes, actinomycetoma. Causative agent further, Madurella mycetomatis, Pseudoaresteria boidi, Acrimonia, Exopila, even Aspergillus can cause. Classification of mycetoma done based on the causative agent. If it is fungi, it is eumycetoma. If it is bacteria, it is actinomycetoma. Based on the color of the grains, bacterial agents, white to yellow grains, they produce kind of a grain. So we can see once we extract these tissues following wound debridement, once we in the laboratory, even in surgical theater, surgeon can observe this. One chop these, we can see kind of tiny bodies or grains later. Depending on the color, we can predict the causative agent. Usually fungal agents black, but there are white grains also there. So this table give a bit of description. So white to yellow, usually no cardia. No cardia also one possibility. Actinomadura maduri, likewise Pseudoalasteria boidi. Brown to black, Madurella mycetomi. Red, Actinomadura maduri. That depends on their grain color. Clinical finding, as I said earlier, it's heat, lower extremities, including hands. It causes abscess formation, draining sinuses containing granules, and in left untreated, it may cause deformities. Also, it can spread to deeper tissues like muscles and bones, causing muscle infection, as well as bone infection to acute and chronic osteomyelitis. Here you can see about mycetoma. Here, the chronic devastating condition, deforming condition also there. You can see. These are the sinuses opening. Here, it's another mycetoma. It's about the sporotrix syncytium. It's which cause spirotrichosis. Same like mycetoma. It's a dimorphic fungi in origin, which cause similar following prawn infection. It causes subcutaneous infection. About the chromoblastomycosis, another variety, but it causes subcutaneous infection caused by Fonsesia pedrosa, Pylopora varicosa, Cladopyrifum carioni, like they are. Peculiar feature is fungi produce characteristic sclerotic or muriform cells. You can see here. This is the muriform cell with the center septate like. If we see in this, it's pathognomic or diagnostic for chromoblastomycosis. So it's an open term, okay? It causes by these fungi, Fonsesia, Pylopora, Cladopyrifum like that. It's about the chromoblastomycosis, so nodular lesion, so no subcutaneous tissue. Nodulous chromoblast by Fonsesia pedrosa. About the diagnosis, often clinical findings are non-specific. Identification of the infecting fungus is difficult. Characteristic of granule, colony morphology, and physiological tests are used for identification. So history is very much important. Occupational history and as well as the disease history, how long, how it occurred, now what is the stage, is there brain sinuses there. Likewise, we can. Even with the experience and we can easily identify. Specimen, grains or granules, pus or exudate or biopsy. For that, lesions clean with antisepsis, then the grains collected by pressing the sinus from the periphery. Size, shape, texture, color of the grains we can identify. Here, Madurella mycetomatous cause the majority of the infection with black grains. It is imperfect. Dermatitis is mould with brown colonies and diffuse honey-colored pigment. You can see several mycelium. KOH mount with the grains, eumycetoma. Now about the what is U. U is a fungal in origin, interwoven hyphae with large swollen cell, whereas actinomycetoma, filaments with diameter with the bacillary forms. Hyphae seen on KOH mount use special stain. That's next. Culture weaken both possibilities of fungi and bacteria. When actinomycetoma is suspected on direct examination, was grains several times with normal saline, then inoculate on SDA without antibiotics. When eumycetoma is suspected, same manner, SDA with antibiotics. Incubated at 25 and 37 in both temperature. That's how we do. It's like the same in what we do in dermatophyte identification. Here also we keep in two temperature, ambient and body temperature. We set this temperature in incubator and we take two from SDA with antibiotics, without antibiotics. Even without suspicion, what we do is SDA, semaroted dextroaceae, one with antibiotic, one without antibiotic. We inoculate these tissue materials and keep in two temperatures. So altogether 4 plates. Management. Taken together, chromoblastomycosis, mycetoma, or Madura foot, or spirotrichosis, all are subcutaneous devastating forming chronic granulomatous infection. So treatment modality is almost similar. Considering eumycetoma, usually treated with long-term antifungal. Surgery amputation also we have to do. Itraconazole prolonged therapy also is the antifungal most often we use. We have to use 6 to 12 months like prolonged therapy. In the second line, we use amphotericin B, second and third generation azoles, terbinafine and echinocandins. You can learn about what are the antifungals. Actinomycetoma, it's the other variety, is usually treated with antibiotics. So U means fungal, actinomycetoma is which caused by actinomyces, bacterial species. And surgery is so often not needed. That's how we treat. Thank you.